several months. We have a number of colleagues here who've very nicely contributed their time and efforts and expertise to help us build these guidelines. And then I'll just take you through a little bit of research that we've been doing here in Canada as well. All right, so we'll just talk about the consensus guidelines a little bit. We'll talk about the SIH registry that we've established in Canada, particularly the two centers that are currently involved, Calgary and Toronto. We'll talk about another study that we've actually set up with Dr. Shivink at Cedars-Sinai, looking at SIH outcomes and the development of a new disability scale for SIH, and then just some hope for the future. So in regards to the Canadian Consensus Guidelines on SIH, this is a collaborative, multidisciplinary project to write Canadian guidelines on the diagnosis and treatment of SIH. And this is evidence as well as expert consensus-based recommendations that we've been working on for the last several months. So our goal is to create a comprehensive and cohesive guideline document that essentially encompasses all the important aspects of this condition, from initial diagnosis all the way to management and post-treatment recommendations. In addition, we wanted to provide a practical approach to diagnosing and managing patients with SIH, in particular for Canada, taking into account resources and facilities that we have available. As well as allow a more standardized approach, because we know that, for example, patients that might be in rural centers or centers where they may not be as much SIH expertise, or the neurological investigations that are required may not have the same access. So really, the goal is also to provide a more standardized approach so that patients from across the country can access care equally, no matter where they are. And also just to highlight some of the gaps of care we have, because obviously, we still have a long way to go to optimize things. So this guideline hopefully will serve also as ammunition for further advocacy and to raise awareness, and hopefully further resources and funds over time. So in regards to our current stage, the guidelines first draft have been completed with a consensus-based, evidence-informed process with a working group of subject matter experts representing neurology, neuroradiology, anesthesiology, neurosurgery, as well as patient advisors. And I'm also happy to add to that psychology as of today as well. We'll have a psychologist provide some input as well in terms of mental health for the guidelines. And input is also being provided by several of our experienced international experts, some of which are here, like Dr. Callan and Dr. Shivink, Dr. Carroll. So thank you all very much for your expertise and time. And in terms of timeline, it's a comprehensive literature review, and that, for the most part, has been completed, but we're continuing to look at new papers that are coming in as well, just to ensure that we're up to date. The first draft of the manuscript has been completed, is currently being revised, and we've also sent out recommendations, formal recommendations, which have been written. We've revised them based on the first round of feedback that we received, and currently are in the sort of midst of the second round of votes to see what changes are required. But we do have very good consensus on many of the recommendations. So we hope for publication in the coming months, so stay tuned. So I'll go on to talk about the next project, which is an SIH registry, and I think many centers are hoping to set this up eventually. And our goal really with these is eventually to have a Canadian registry for SIH, where most centers will be involved. But unfortunately, it takes a lot of funding for that. So we're starting slow with just a couple of centers, but still, getting some good data in as well. So currently we have two of our largest centers in Canada, University of Calgary and University Health Network in Toronto, involved. And this is a comprehensive SIH registry to collect data on clinical, radiographic, procedural, and surgical aspects of this condition in adult patients diagnosed with SIH by a specialist. And we purposely included a high degree of clinical suspicion in this database as well, in addition to ICHD3 diagnosis, because we wanted to ensure that, again, we're not missing some of those patients. But we will certainly look at those variables separately later on as well to see if there's differences between those that do not conform to ICHD versus those that do. And Sunnybrook Hospital in Toronto is actually currently submitting the study to their ethics board as well, so hopefully they will be involved. And these are the people that are involved, so myself, and we have some of our fellows from the University of Calgary, Dr. Christensen and Dr. Aldawali. Dr. Christensen was actually a previous fellow, now working as a headache specialist in Victoria, BC. And then in University Health Network here, we have Dr. Hoydonks, as well as several of her team, Danielle Alvarez, Anna Kaleitner, and Aparna Sarapella. And then I just wanted to acknowledge as well that funding for this actually has come from Spinal CSF League Canada. So thank you very much for allowing us to pursue this research. Without it, it would not be possible. We have a biostatistician that is helping us with analysis. And then, of course, Ms. Bahare Cloutier herself, that's also involved as the chair and founder of Spinal CSF League Canada, and has been involved in drawing some of the graphs for us as well. So this is our first research study from this registry. So the way the registry is set up is that we can actually ask any potential research question. We just have to submit that to our ethics board for that particular research question. So this was our first research study question that we wanted to ask was, how well are we doing in terms of epidural blood patching here in Canada, at least in these two centers, so at the U of C and the U of T. How well are patients doing? What are their outcomes? What are the patients like? What's the characteristics of the patients? And the registry continues to actively recruit patients. So just keep in mind that the numbers are still somewhat small when I show you on the subsequent slides, but it will continue to hopefully include a number of patients over the coming months. But essentially, our first research question was to characterize the population of patients and then assess response to blood patching and determine what factors may influence that response. And our hypothesis, based on literature, was that people that have sustained response to blood patching have significant different clinical, imaging, or blood patch-related characteristics or factors compared to those that don't have sustained response. And we define sustained response as significant to complete relief of symptoms. So that included headache as well as other symptoms for at least 4 weeks, so 4 weeks or longer. They could still have a mild headache, but overall they would have a substantial reduction in their headache. So far, we've had 78 patients included in the data analysis. Some patients may not have variables for, or data for all of the variables, so you might see some of the numbers are a little bit lower, but generally 78 patients were included. Mean age was about 53 with 59% female, so very similar to other cohorts published. Mean BMI was 27. Only 3 out of the 68 patients, or about 4%, had an underlying connective tissue disorder. So even though we know that there may be this association, we actually don't see it very commonly in clinic. So only about 4% had a connective tissue disorder. Disease duration was documented for 46 patients. Unfortunately, for some, it was not documented, and we will try to go back and obtain that data. But as you can see here, the numbers are actually quite high, especially for those having long durations of disease. So almost a quarter of patients reported 1 to 2 years of disease, 20% had 2 to 5 years of disease, and almost another quarter had 5 to 15 years of disease. So here we're dealing with patients that, again, have had long-standing symptoms. So very few were actually seen within that first year. And then of the 78 patients, almost all, so close to 99%, had headache. So the vast majority of these patients do have headache. These are some of the clinical characteristics of the patients. So you can see that headache onset more commonly occurred either acutely or over days. Thunderclap was described in about 13%, but that wasn't the most common presentation. In terms of headache location, you can see occipital was the most common and up to about 60% of patients, but frontal and temporal were also described. And then the majority of patients described severe headache intensity. There was no patients that described mild headache intensity, so it was moderate to severe, with the majority being severe. As you can see, most were bilateral as well in that bottom diagram. 83% had orthostatic headache at onset when their symptoms first began, from what they could recall. And about 80% continued to have orthostatic headache during the clinic visit. So, it does drop down a little bit from the onset of symptoms, but it actually persisted to be almost the same number as when they first started. Some patients will have continuous headache, and others will have exertional headache. So about 50% will have about exertional headache. In terms of associated symptoms, most common nausea, followed by photophobia and phonophobia, but altered hearing, neck stiffness, and tinnitus were also quite common. So these are some of the numbers that we saw in terms of imaging and lumbar puncture. So of 134 MRIs of the brain that were done, this is pre-treatment with epidural blood patching for these patients, 74% were abnormal, and the most common abnormalities were what we tend to see. So sagging of the brain, enhancement of the pachymeninges, and venous engorgement. And then of 102 spinal MRIs that were performed, 80% were abnormal, with the most common abnormality seen being spinal epidural fluid collections, or SLECs. And then of 57 DSM, 77% were abnormal. And in those that did report the type of CSF leak that was found, 41% had ventral dural tears, 41% had a CSF venous fistula, and 18% had a proximal nerve root tear. So predominantly we're seeing ventral dural tears and CSF venous fistulas. And then only 12 patients had lumbar punctures, which is what we want to see. We want to see a low number of patients have LPs unless it's necessary for another reason to do it. And only 2 of these, so only 16% showed a low opening pressure. The rest were normal. So again, another reason not to do these lumbar punctures. In regards to our results with the blood patching, so I'll start with the non-directed epidural blood patch outcomes first. So there was 92 of those done, the most common level at L2-3. 28 out of 92, or about 30%, met criteria for sustained response, so not very good at all. And I'll get into some of the potential reasons for that. And then we found that age, sex, BMI, duration of disease, presence or absence of orthostatic headache severity, none of those really seemed to make a difference, unfortunately. Level of blood patch did not seem to have a bearing on the results either, so those that had higher level or lower level ones, it didn't seem to show a difference in terms of response. But what we did find, which was consistent with other studies, is that responders were more likely to have volumes greater than 20 mLs injected. That was 86% of responders versus for non-responders, that was 58%. So the odds of responding for those that received higher volume above 20 ml was about 4.3. So pretty good odds. So that's definitely an important factor, is that volume greater than 20 ml. Image guidance in this case did not seem to have a bearing on response, and MRI brain results also did not seem to have a bearing. But patients that have had abnormal MRIs of the spine were more likely to respond to non-directed blood patching. So the odds were actually around 5 times for those that had an abnormal MRI versus those that did not have an abnormal MRI. And here it was mostly defined by that spinal longitudinal epidural fluid collection. Post-blood patch symptoms reported in about 16%, the majority of those being back pain and resolving generally within a few weeks. And we found that in this cohort, 20% reported rebound intracranial hypertension. So again, consistent with the numbers that we're seeing in the literature. In regards to the directed blood patches, so far we don't have that many. It's 29 here in this cohort. Most common levels were mid-thoracic and then L2-3. 87% of these were image-guided, so there was a few that were not image-guided. And then of these, 37.9%, or about 38%, met criteria for sustained response. So a little bit better compared to non-targeted, but definitely still not very good results overall. And again, a lot of those factors that we discussed previously did not seem to have a bearing, except that responders seem to have a shorter duration of disease, about 1.4 years for the mean, compared to about 5.5 years for those that did not respond. So that does seem to make a difference, although the statistical significance here was not shown, but the trend was definitely seen. There didn't seem to be a difference in terms of volume of blood in this case for directed blood patching or level of blood patch. And imaging results of the brain or spine also did not seem to make a difference in terms of response. Similar results to the non-directed patching in terms of post-epidural blood patch related symptoms. So about 21% had symptoms they described, mostly again back pain that was mild and resolved. And then 17% experienced RIH in this case. So in conclusion, for this SIH registry, I think what we can see here from this data is that, unfortunately, we're seeing that a lot of patients take a long time to be seen because of the issues that we've just discussed based on our Canadian survey. We know that it's taking a long duration of time for patients to get to us. So hopefully we can, by advocacy and education, get these patients to us sooner. Nearly all patients had headache, mostly having orthostatic headache, and 70% reporting that it was severe. MRI demonstrated evidence of SIH in nearly 74% and 80% of brain and spine studies, respectively. Lumbar puncture was rarely performed and mostly showed normal opening pressure. So again, do not use that as a diagnostic tool for SIH. In our cohort, ventral dural leaks and CSF venous fistulas were the most common types of leaks that we saw. For non-directed blood patches, only 30% had sustained response. Abnormal MRI of the spine and blood patch volume above 20 were predictive of better response. For the directed patching, 38% had sustained response. In this case, we saw that shorter duration of disease was supportive of a better outcome. So just in terms of overall conclusion, our study certainly does show lower response rates in the epidural blood patches compared to other studies that have been published. The likely reason I think for this is that our population has long durations of disease, and we know that, unfortunately, that can be a predictor of, less favorable outcome, especially for certain types of leaks like those ventral dural tears, where, conventional blood patching tends to be less effective. Patients in Canada are just not receiving the diagnosis and treatment in a timely fashion. So again, that's something for us to work on. So we must continue to raise awareness and education, advocate for more resources in Canada, and hopefully improve access for patients across the country. Just briefly to discuss this study as well, I won't get into details, but just to mention that what we're doing. So we're doing another study called the SIH Outcome Study with ourselves at the University of Calgary in collaboration with Dr. Shivenka's Cedars-Sinai Medical Center and his team there, Rachel and Liana, who's the research assistant, again funded by Spinal CSF League Canada. This utilizes the SIH registry that I was just describing, but in addition, we'll be collecting data prospectively on several patient-reported outcomes. Those include things like headache intensity with a new disability scale that we're designing, but also, various other factors like depression, anxiety, quality of life, a number of factors that the patients will fill out, and it will be prospective, so hopefully we'll have some good outcome results from that. And this will look at all patients, so patients who've had blood patching, embolization, surgery, and we'll follow them actually up to 5 years. So that data is not currently available yet because we've just recently started this study, so we need some time to collect that data. But one thing I wanted to mention is this disability scale that we've developed in collaboration with Dr. Shivenk. And we're kind of starting that process of validating it. It's actually quite exciting. So at this time, as you know, there's no validated disability scale specific to spinal CSF leak. So we set out to develop that and went through kind of a rigorous evaluation process actually to start that off. It went through a number of reviews by physicians and experts as well as patients, received feedback, and then was reduced to 12 items. So it's a 12-item scale that we're calling Spinal CSF Leak Disability Scale. And so far, our preliminary results, again, it's very early and we need more data, but our preliminary results show that the scale demonstrates strong content validity, so the questions seem to be valid and appropriate in regards to disability, and excellent internal consistency, that alpha coefficient being 0.95, so the questions are well interrelated. So hopefully this will be a future publication with a new scale that hopefully we'll have available for use. So again, watch for that hopefully in the coming months. So just lastly, a little bit of hope for the future. So hopefully once more data is collected on both of these studies, they will be published and submitted for publication. And Canadian and international research has continued to grow. As Dr. Hoydong showed, the publications, they continue to grow. So there's definitely hope for the future in terms of improving our diagnosis, diagnostic imaging modalities, as well as management of this condition. And I just want to, again, say thank you to Spinal CSF League Canada. They've been instrumental in providing funding for these research studies, so we're very grateful to them. And there's also a newly established International Society for Spinal CSF Leak that is being led by Dr. Peter Kranz and Dr. Werner Becker here, where this will be hopefully an international forum for collaboration, research, and education. And if you're interested, they do have a website and they're accepting memberships. But hopefully this international collaboration will allow a lot more studies to be done, multi-center, hopefully randomized controlled trials and other things down the road. And we must continue our efforts to support advocacy, education, and research, and hopefully these will improve our understanding for the diagnosis and treatment of SIH, but I think that the future looks bright. So thank you.